Welcome back to the channel where we turn tough NCLEX questions into your easiest wins. Today's focus is one of the hardest areas students struggle with, gynecology nursing, and trust me, these 50 questions will test everything you know. Don't click away, because each question comes with clear, exam-style rationales that will help you think like a real NCLEX pro. So grab your notebook, settle in, and let's see if you can get all 50 right. Let's begin. Question 1. A 34-year-old woman presents with sudden onset severe pelvic pain and syncope. She has an IUD in place placed 2 years ago. Vitals, BP 88/50ths, HR 128, RR 24. On exam she has diffuse abdominal tenderness and rebound. Which is the nurse's priority action? A. Remove the IUD immediately. B. Start 2 large bore 4 lines and give isotonic crystalloid bolus. C. Prepare the patient for pelvic ultrasound. D. Administer intramuscular morphine for pain. Answer: B. Start 2 large bore 4 lines and give isotonic crystalloid bolus. Rationale: the patient is hypotensive and tachycardic, signs of hypovolemic shock. Immediate stabilization, airway/breathing/circulation, is priority. 2 large bore IVs and fluid resuscitation are life-saving. Imaging and procedures follow after stabilization. Analgesia is important but not before stabilizing circulation. Question 2. A patient with suspected ectopic pregnancy has a quantitative beta-HCG of 1,200 ml/ml and a transvaginal ultrasound that shows no intrauterine pregnancy. She is hemodynamically stable. Which intervention is most appropriate? A. Give methotrexate IM after confirming eligibility. B. Immediate laparotomy. C. Reassure and repeat beta-HCG in 2 weeks. D. Administer Rh immune globulin and discharge. Answer: A. Give methotrexate IM after confirming eligibility. Rationale: in a stable patient with non-diagnostic ultrasound and beta-HCG in the discriminatory zone without intrauterine pregnancy, methotrexate medical management is appropriate if criteria met: no rupture, small mass less than 3.5 to 4 centimeters, no fetal cardiac activity, reliable follow-up. Laparotomy is for unstable/ruptured cases. Repeating in 2 weeks delays care. ROGAM is indicated if Rh negative, but not sole intervention. Question 3. Select all that apply. Which findings increase suspicion for ovarian torsion? A. Sudden unilateral lower abdominal pain. B. Vomiting and nausea. C. Low-grade fever with diffuse pelvic tenderness. D. Doppler ultrasound showing absent or decreased ovarian blood flow. E. Gradual bilateral pelvic heaviness worse with standing. Answer: A, B, D. Rationale: ovarian torsion typically presents with sudden severe unilateral pain, nausea/vomiting, and ultrasound may show decreased or absent blood flow. Low-grade fever may occur but diffuse pelvic tenderness and fever more suggest infection. Bilateral gradual heaviness is less typical for torsion. Question 4. A 45-year-old woman with heavy menstrual bleeding is being treated with high-dose combined oral contraceptives. She reports new unilateral leg swelling and pain. Which action should the nurse take first? A. Stop the combined oral contraceptive immediately. B. Encourage leg elevation and NSAIDs. C. Assess for signs of deep vein thrombosis and notify provider. D. Suggest switch to transdermal patch. Answer: C. Assess for signs of deep vein thrombosis and notify provider. Rationale: unilateral leg swelling/pain could indicate DVT, a known risk with estrogen-containing contraceptives. Immediate assessment: circumference, Holman's not reliable, urgent notification, and appropriate testing, D-dimer, ultrasound, are required. Stopping OCP and supportive measures follow after assessment. Question 5. A 28-year-old presents with frothy, malodorous vaginal discharge and pruritus. Wet mount with KOH shows clue cells. What is the most likely diagnosis and appropriate treatment? A. Trichomoniasis, metronidazole oral. B. Bacterial vaginosis, oral metronidazole or intravaginal clindamycin. C. Candidiasis, fluconazole PO. D. Atrophic vaginitis, topical estrogen. Answer: B. Bacterial vaginosis, oral metronidazole or intravaginal clindamycin. Rationale: clue cells, epithelial cells coated with bacteria, are characteristic of BV, discharge often fishy, gray, homogeneous. Metronidazole oral or intravaginal clindamycin is standard. Trichomonas typically shows motile flagellates on wet mount, candidiasis demonstrates budding yeast/hyphae. Question 6. A 62-year-old woman has postmenopausal bleeding. Which diagnostic step is highest priority? A. Transvaginal ultrasound and endometrial sampling, biopsy. B. Check serum estrogen levels. C. Prescribe estrogen therapy to relieve atrophy. D. Observe for recurrence over 6 months. Answer: A. Transvaginal ultrasound and endometrial sampling, biopsy. Rationale: postmenopausal bleeding is abnormal and requires prompt evaluation for endometrial carcinoma. TVUS can estimate endometrial thickness, endometrial biopsy is diagnostic. Estrogen therapy and observation without diagnosis are inappropriate. Question 7. A patient receiving chemotherapy for ovarian carcinoma has thrombocytopenia, platelets 18,000/mm superscript 3, and vaginal spotting. What is the best immediate nursing action? A. Apply pressure to perineum and administer platelet transfusion as ordered. B. Begin high-dose estrogen to stop bleeding. C. Encourage ambulation to reduce stasis. D. Give ibuprofen for discomfort. Answer: A. Apply pressure to perineum and administer platelet transfusion as ordered. Rationale: platelets 20,000/mm superscript 3 increase bleeding risk. Active bleeding requires hemostatic measures and platelet transfusion per orders. NSAIDs are contraindicated due to platelet dysfunction. Ambulation may worsen bleeding. Question 8. A 30-year-old with PCOS wants to conceive. Her BMI is 38 kilograms per square meter. Which initial recommendation will most improve fertility? A. Start clomiphene citrate immediately. B. Begin weight loss through diet/exercise and consider metformin. C. Begin gonadotropin therapy. D. Start combined OCPs to regulate cycles. Answer: B. Begin weight loss through diet/exercise and consider metformin. Rationale: in obese women with PCOS, weight loss improves ovulation and fertility. Metformin may help insulin resistance and ovulation. Clomiphene is considered after lifestyle measures. OCPs are contraceptive, not for conception. Question 9. A 22-year-old presents with lower abdominal pain, fever, and purulent cervical discharge. She is diagnosed with PID. Which of the following is the most critical teaching point? A. Sexual partners should be treated. B. Use acetaminophen for fever. C. Avoid pregnancy for at least 3 months. D. Resume sexual activity when symptoms subside. Answer: A. Sexual partners should be treated. Rationale: treating sexual partners prevents reinfection and is public health critical. Other teaching points are valid: avoid unprotected sex until treatment complete, but partner treatment is essential. Question 10. A patient with heavy fibroid-related bleeding is being considered for uterine artery embolization, UAE. Which statement indicates appropriate patient selection? A. She desires future fertility and is 28 years old. B. She wants uterine conservation and does not desire future pregnancy. C. She has a suspected leiomyosarcoma. D. She has infection of the uterus. Answer: B. She wants uterine conservation and does not desire future pregnancy. Rationale: UAE preserves the uterus but may impair fertility. It's appropriate for women who want uterine preservation but not future pregnancy. Suspected malignancy or infection are contraindications. For young patients desiring fertility, myomectomy is preferred. Question 11. A 39-year-old with stage 2 endometrial cancer asks if her obesity contributed. Which pathophysiologic mechanism best explains increased endometrial cancer risk with obesity? A. Obesity decreases LH/FSH leading to hyperplasia. B. Excess peripheral conversion of androgens to estrogen in adipose tissue. C. Obese persons are more likely to have STIs, increasing risk. D. Increased insulin resistance prevents endometrial proliferation. Answer: B. Excess peripheral conversion of androgens to estrogen in adipose tissue. Rationale: adipose tissue converts androgens to estrogens via aromatase unopposed estrogen exposure, endometrial hyperplasia and carcinoma risk. Insulin resistance and hyperinsulinemia also contribute, but the aromatase mechanism is classic. Question 12. A 17-year-old with secondary amenorrhea for 6 months, BMI 16, reports intense exercise and weight loss. Labs: low FSH, low LH, low estrogen. Best explanation? A. Primary ovarian failure. B. Hypothalamic amenorrhea due to energy deficit. C. Hyperprolactinemia. D. Polycystic ovarian syndrome. Answer: B. Hypothalamic amenorrhea due to energy deficit. Rationale: low gonadotropins and estrogen with history of weight loss/excess exercise indicate hypothalamic amenorrhea, functional hypothalamic amenorrhea. Primary ovarian failure would have high FSH/LH. Hyperprolactinemia shows low GnRH but with elevated prolactin. PCOS typically has normal/raised androgens with oligomenorrhea. Question 13. A patient with cervical cancer of the transformation zone is scheduled for cone biopsy, LEEP. Which pre-procedure nursing action is essential? A. Verify pregnancy status with urine or serum HCG. B. Give prophylactic antibiotics for every patient. C. Ensure patient fasts 8 hours prior. D. Apply topical estrogen pre-op. Answer: A. Verify pregnancy status with urine or serum HCG. Rationale: pregnancy is a contraindication for some cervical procedures. Always confirm pregnancy status. Routine antibiotics are not mandated for all. Fasting and topical estrogen are not standard pre-LEEP. Question 14. Select all that apply. Risk factors for cervical cancer include: A. HPV infection, ESP type 16, 18. B. Early onset sexual activity and multiple partners. C. Long-term combined OCP use alone without HPV. D. Smoking. E. Obesity, BMI greater than 35. Answer: A, B, D. Rationale: HPV infection, sexual behavior factors, and smoking are established risk factors. Long-term OCPs slightly increase risk but primarily in presence of HPV. Obesity is not a primary cervical cancer risk, more endometrial. Question 15. A 26-year-old with HSV-2 genital lesions asks about transmission risk during asymptomatic viral shedding. Which is correct? A. No risk when there are no lesions. B. Transmission can occur during asymptomatic shedding. Condoms reduce but don't eliminate risk. C. Antiviral suppression increases shedding and risk. D. Only newborns are at risk from asymptomatic shedding. Answer: B. Transmission can occur during asymptomatic shedding. Condoms reduce but don't eliminate risk. Rationale: HSV can be transmitted during asymptomatic shedding. Suppressive antivirals reduce shedding and transmission risk. Condoms reduce but cannot eliminate risk entirely. Question 16. A patient with vulvar lichen sclerosus has severe pruritus and white plaques. She asks about malignant potential. What's the best response? A. It never leads to cancer. B. It increases risk for vulvar squamous cell carcinoma. Regular follow-up and biopsy of suspicious areas needed. C. Topical estrogen prevents malignancy. D. Only elderly patients are at risk. Answer: B. It increases risk for vulvar squamous cell carcinoma. Regular follow-up and biopsy of suspicious areas needed. Rationale: lichen sclerosus increases risk for vulvar SCC. Close surveillance and biopsy of suspicious lesions are recommended. Topical high-potency steroids treat symptoms but do not eliminate risk entirely. Question 17. A 35-year-old woman with recurrent bacterial vaginosis, BV, asks for prevention strategies. Which interventions should you teach? Select all that apply. A. Avoid douching. B. Use oil-based lubricants and scented feminine washes. C. Encourage condom use and reduce multiple sexual partners. D. Breastfeed exclusively. E. Consider probiotic therapy, some evidence. Answer: A, C, E. Rationale: douching disrupts normal flora and increases BV condoms and fewer partners reduce recurrence. Some evidence supports probiotics, oil-based/scented products can increase irritation and dysbiosis. Breastfeeding is irrelevant. Question 18. A 48-year-old with abnormal uterine bleeding has a biopsy showing complex atypical endometrial hyperplasia. She desires future fertility but also has obesity and insulin resistance. Which is optimal management? A. Total hysterectomy with bilateral salpingo-oophorectomy immediately. B. High-dose progestin therapy and close surveillance. C. Watchful waiting without treatment. D. Start tamoxifen. Answer: B. High-dose progestin therapy and close surveillance. Rationale: for complex atypical hyperplasia in women desiring fertility, high-dose progestins, oral or levonorgestrel IUD, with close follow-up is an accepted conservative approach. Hysterectomy is definitive but precludes fertility. Question 19. A patient with suspected ovarian cancer has CA-125 elevated to 120 U/ml. What is the nurse's role regarding the significance of CA-125? A. Explain CA-125 is diagnostic of ovarian cancer. B. Educate that CA-125 can be elevated in benign conditions and is not diagnostic alone. C. Reassure CA-125 is always normal in early ovarian cancer. D. Tell patient CA-125 predicts immediate mortality. Answer: B. Educate that CA-125 can be elevated in benign conditions and is not diagnostic alone. Rationale: CA-125 is a tumor marker elevated in many gynecologic and non-gynecologic conditions, not diagnostic alone. It may be normal in some early ovarian cancers, used for monitoring disease rather than solely diagnosing. Question 20. Prioritization: a woman arrives with heavy vaginal bleeding soaking 2 pads/hour, pulse 130, BP 84/46, and a history of von Willebrand disease. Order the priority actions. 1. Administer 4 fluids and blood products as ordered. 2. Apply oxygen and monitor vitals. 3. Prepare for possible emergent uterine tamponade or surgical intervention. 4. Give desmopressin, DAP, as per hematology recommendations. Answer: priority, 2143, apply oxygen/monitor, start 4 fluids/blood, give DAP per order, prepare for tamponade/surgery. Rationale: ABCs first, oxygen, monitoring. Rapidly restore circulating volume next. For VWD, DAP may be ordered to increase factor VIII/VWF levels, after notifying hematology. If bleeding persists despite medical measures, mechanical or surgical interventions follow. Question 21. A 29-year-old postpartum woman, 10 days, presents with fever, uterine tenderness, and purulent lochia. She is diagnosed with endometritis. Which nursing action is most important initially? A. Administer broad-spectrum 4 antibiotics per order. B. Encourage breastfeeding to decrease uterine size. C. Obtain pap smear. D. Apply heat packs. Answer: A. Administer broad-spectrum 4 antibiotics per order. Rationale: endometritis postpartum can be severe. Early 4 antibiotics, broad-spectrum covering anaerobes, are crucial. Breastfeeding and other measures are supportive. Pap smear is unrelated. Question 22. A 52-year-old on tamoxifen therapy reports vaginal spotting. Which condition should you suspect and report promptly? A. Endometrial hyperplasia or carcinoma. B. Vaginal atrophy only. C. Normal side effect requiring no action. D. Ectopic pregnancy. Answer: A. Endometrial hyperplasia or carcinoma. Rationale: tamoxifen has estrogen agonist effects on endometrium, increasing risk of hyperplasia and cancer. Postmenopausal vaginal bleeding on tamoxifen warrants prompt evaluation with pelvic exam and endometrial sampling. Question 23. Which contraceptive method is contraindicated in a woman with a history of stroke and current migraine with aura? A. Levonorgestrel IUD. B. Progestin-only pill. C. Combined estrogen-progestin oral contraceptive pill. D. Copper IUD. Answer: C. Combined estrogen-progestin oral contraceptive pill. Rationale: estrogen-containing contraceptives increase thrombotic risk and are contraindicated in those with history of stroke or migraine with aura. Progestin-only methods and IUDs are safer alternatives. Question 24. A 31-year-old with primary syphilis has a penicillin allergy. She is pregnant. Which is appropriate? A. Use doxycycline as alternative. B. Desensitize and treat with penicillin. C. Azithromycin single dose. D. No treatment until after delivery. Answer: B. Desensitize and treat with penicillin. Rationale: in pregnancy, penicillin is the only proven effective therapy to prevent congenital syphilis. Allergic patients should be desensitized and treated with penicillin. Doxycycline and azithromycin are contraindicated in pregnancy or insufficient. Question 25. A woman in her late 30s has a Bartholin gland abscess. Which management is most appropriate for a fluctuant 3 cm abscess? A. Immediate excision of gland under local anesthesia in clinic. B. Word catheter placement, marsupialization, or incision and drainage with word catheter. C. High-dose systemic steroids. D. Observe without intervention. Answer: B. Word catheter placement, marsupialization, or incision and drainage with word catheter. Rationale: for Bartholin abscesses, IND with word catheter or marsupialization preserves gland function and prevents recurrence. Simple excision may be done in recurrent cases or older women due to cancer risk, but initial approach for a 3 cm fluctuant abscess in younger women is drainage with catheter. Question 26. A patient undergoing pelvic radiation for cervical cancer will likely experience which acute side effects? Select all that apply. A. Diarrhea and bowel irritation. B. Vaginal stenosis and dryness. C. Hyperactive ovarian function. D. Skin erythema in radiation field. E. Profound polyuria. Answer: A, B, D. Rationale: pelvic radiation commonly causes bowel irritation/diarrhea, local skin changes, and vaginal mucosal changes leading to stenosis and dryness. Radiation causes ovarian failure, not hyperactivity. Polyuria is not typical. Question 27. A woman with suspected polycystic ovary syndrome, PCOS, presents with irregular menses, hirsutism, and insulin resistance. Which lab/test best supports diagnosis? A. Random serum cortisol. B. Elevated LH-FSH ratio and ovarian ultrasound showing multiple small follicles. C. Serum progesterone greater than 20 nanograms per milliliter. D. Positive pregnancy test. Answer: B. Elevated LH-FSH ratio and ovarian ultrasound showing multiple small follicles. Rationale: PCOS often shows increased LH-FSH ratio and polycystic ovarian morphology on ultrasound. Other tests help exclude other causes: thyroid, prolactin, androgens. Question 28. A 25-year-old presents with pelvic pain and cyclic rectal bleeding that increases during menses. Pelvic exam and MRI are consistent with deep infiltrating endometriosis involving the rectovaginal septum. What is the best multidisciplinary management approach if she desires fertility? A. Hysterectomy with bilateral oophorectomy. B. Conservative surgical excision of endometriotic lesions with preservation of anatomy plus fertility planning and possible assisted reproduction. C. High-dose combined OCPs indefinitely. D. Expectant management only. Answer: B. Conservative surgical excision of endometriotic lesions with preservation of anatomy plus fertility planning and possible assisted reproduction. Rationale: for severe deep infiltrating endometriosis in women desiring fertility, conservative excision by experienced surgeons plus fertility planning, including ART if needed, offers symptom relief and improved fertility prospects. Hysterectomy/oophorectomy eliminates fertility. Question 29. A 21-year-old female with amenorrhea and galactorrhea has prolactin 150 nanograms per milliliter, normal less than 20. MRI shows a 9 mm pituitary microadenoma. What is first-line treatment? A. Surgical transsphenoidal resection. B. Dopamine agonist therapy, e.g., cabergoline. C. Radiation therapy. D. High-dose estrogen therapy. Answer: B. Dopamine agonist therapy, e.g., cabergoline. Rationale: prolactinomas, microadenomas, are typically treated medically with dopamine agonists to normalize prolactin and shrink tumor. Surgery reserved for refractory cases or intolerance. Question 30. A patient with advanced vulvar carcinoma will undergo radical vulvectomy with bilateral inguinal femoral lymphadenectomy. Which postoperative complication is most likely and should be anticipated/educated about? A. Lymphedema of lower limbs. B. Pulmonary embolism is impossible in these surgeries. C. Hyperpigmented rash around the surgical site only. D. Decreased risk of infection. Answer: A. Lymphedema of lower limbs. Rationale: lymphadenectomy disrupts lymph drainage, commonly causing lymphedema in lower extremities and groin. P is a possible complication in major surgeries, not impossible. Infection risk increases post-op. Question 31. A 33-year-old with persistent HPV-16 positive high-grade squamous intraepithelial lesion, HSIL, has colposcopy-directed biopsy consistent with CIN3. She plans future pregnancies. Which is the preferred treatment? A. Ablation, cryotherapy, only. B. Excisional procedure, cold knife conization or LEEP, to obtain margins and rule out invasive disease. C. No treatment, observe. D. Total hysterectomy. Answer: B. Excisional procedure, cold knife conization or LEEP. Rationale: CIN3 requires excisional management to both treat and evaluate for occult invasion. For fertility desires, cone biopsy, CKC, or LEEP with clear margins is preferred. Ablation doesn't provide tissue for pathology. Question 32. A 40-year-old female is being treated with luprolide, GnRH agonist, for fibroids prior to surgery. She asks why hot flashes occur after starting therapy. What is the best explanation? A. GnRH agonists block estrogen completely from day 1. B. Initial flare increases sex steroids, then profound suppression leads to hypoestrogenic state causing vasomotor symptoms. C. Hot flashes are unrelated to luprolide. D. Luprolide increases progesterone causing hot flashes. Answer: B. Initial flare increases sex steroids, then profound suppression leads to hypoestrogenic state causing vasomotor symptoms. Rationale: GnRH agonists initially cause a transient flare of gonadotropins and sex steroids, then downregulate receptors causing hypoestrogenism, which leads to menopausal symptoms like hot flashes. Question 33. A woman with gestational trophoblastic disease, molar pregnancy, has a beta-HCG that has plateaued at a low but detectable level for 4 months after suction curettage. What is the likely diagnosis and next step? A. Complete resolution, no further follow-up. B. Persistent gestational trophoblastic neoplasia, consult oncology for chemotherapy. C. Ectopic pregnancy, perform laparoscopy. D. Hydatidiform mole recurrence, repeat curettage immediately. Answer: B. Persistent gestational trophoblastic neoplasia, consult oncology for chemotherapy. Rationale: plateauing or rising beta-HCG after molar evacuation suggests persistent GTN requiring oncology evaluation for chemotherapy. Repeat curettage is not first line for persistent disease with plateauing HCG. Question 34. A patient with recurrent vulvovaginal candidiasis has poorly controlled diabetes. Which intervention is most likely to reduce recurrence? A. Strict glycemic control and appropriate antifungal therapy. B. Prolonged course of topical steroids. C. High-dose systemic antibiotics. D. Increased sugar intake to starve yeast. Answer: A. Strict glycemic control and appropriate antifungal therapy. Rationale: poor glycemic control predisposes to candidal infections. Controlling blood glucose plus antifungal therapy reduces recurrence. Steroids worsen infection risk. Question 35. Select all that apply. Which signs/symptoms suggest ovarian hyperstimulation syndrome, OHSS, after fertility treatment? A. Rapid weight gain and abdominal distension. B. Oliguria and hemoconcentration, elevated hematocrit. C. Severe dyspnea and pleural effusion. D. Hyperreflexia. E. Hypotension from third spacing. Answer: A, B, C, E. Rationale: OHSS presents with rapid weight gain, ascites/abdominal distension, oliguria, hemoconcentration, respiratory compromise from pleural effusions, and hypotension due to fluid third spacing. Hyperreflexia is not typical. Question 36. A 24-year-old with primary amenorrhea has normal secondary sexual characteristics, a short blind-ending vagina, and a karyotype 46XX. Best likely diagnosis? A. Androgen insensitivity syndrome. B. Mullerian agenesis, Mayer-Rokitansky-Kusterhauser syndrome. C. Turner syndrome. D. Congenital adrenal hyperplasia. Answer: B. Mullerian agenesis, Mayer-Rokitansky-Kusterhauser syndrome. Rationale: normal secondary sexual characteristics plus blind-ending vagina plus 46XX suggests Mullerian agenesis, absent uterus and upper vagina. Androgen insensitivity is 46XY. Turner is 45X and typically has absent secondary sexual development. Question 37. A nurse is counseling a patient prescribed the levonorgestrel IUD, Mirena. Which statement indicates correct understanding? A. It will protect me from HIV and STIs. B. My periods will likely lighten and may stop over time. C. I must remove it every 3 months. D. It contains estrogen to regulate my cycles. Answer: B. My periods will likely lighten and may stop over time. Rationale: levonorgestrel IUD often reduces menstrual bleeding and can cause amenorrhea in some. It does not protect against STIs/HIV, is long-acting, up to 5+ years, and contains progestin only. Question 38. A woman with acute hemorrhagic ovarian cyst rupture presents with peritonitis and hypotension. She is taken to OR. Which intraoperative nursing preparation is most crucial? A. Type in cross-match for blood products, anticipate transfusion. B. Prepare PROMs, patient-reported outcome measures. C. Ensure bowel prep is completed. D. Schedule MRI post-op. Answer: A. Type in cross-match for blood products, anticipate transfusion. Rationale: ruptured hemorrhagic cyst with hemodynamic instability can lead to significant blood loss, blood products must be ready. Bowel prep and MRIs are not immediate priorities. Question 39. Which medication is contraindicated during pregnancy for treating bacterial vaginosis? A. Metronidazole oral. B. Clindamycin cream given intravaginally. C. Tetracyclines, e.g., doxycycline. D. Oral clindamycin. Answer: C. Tetracyclines, e.g., doxycycline. Rationale: tetracyclines are contraindicated in pregnancy, affect fetal bone/teeth. Metronidazole and clindamycin are acceptable with considerations. BV in pregnancy should be treated to reduce preterm birth risk. Question 40. A 46-year-old woman with suspected cervical stenosis after radiation complains of postcoital bleeding and dyspareunia. What is likely and what test is indicated? A. Cervical stenosis causing hemadometra, pelvic ultrasound to evaluate fluid collection. B. Pregnancy, beta HCG. C. Ovarian torsion, CT scan abdomen. D. UTI, urinalysis only. Answer: A. Cervical stenosis causing hemadometra, pelvic ultrasound to evaluate fluid collection. Rationale: radiation can lead to cervical stenosis causing retained blood, hemadometra, with pain and bleeding. Pelvic ultrasound evaluates uterine fluid. Pregnancy is unlikely at 46, but beta-HCG could be considered if indicated. Question 41. A 19-year-old with amenorrhea and very high testosterone, hirsutism, and a pelvic mass on ultrasound, suspicion is for an androgen-secreting ovarian tumor. Which diagnostic measure is priority? A. Serum tumor markers, AFP, LDH, inhibin, DHEAS, and prompt referral for surgical evaluation. B. Start oral contraceptive therapy and follow up in 6 months. C. Reassure and advise shaving for hirsutism. D. Biopsy the mass by a transvaginal needle aspiration. Answer: A. Serum tumor markers and prompt referral for surgical evaluation. Rationale: rapid onset virilization and pelvic mass raise concern for androgen-secreting tumor. Evaluate with appropriate labs, DHEAS, testosterone, inhibin, and refer for surgical management. Needle biopsy of adnexal masses is generally avoided due to risk of rupture/spread. Question 42. A patient with severe menstrual pain that limits daily activities has been non-responsive to NSAIDs and combined OCPs. Next best management step? A. Consider diagnostic laparoscopy to evaluate for endometriosis and treat lesions. B. Increase NSAIDs dose indefinite. C. Recommend elective hysterectomy immediately. D. Suggest lifestyle changes only. Answer: A. Consider diagnostic laparoscopy to evaluate for endometriosis and treat lesions. Rationale: if conservative therapy fails and symptoms are severe, laparoscopy for diagnosis and treatment of endometriosis is appropriate. Hysterectomy is not first line, especially in younger women. Question 43. A 55-year-old with known BRCA1 mutation asks about risk-reducing options. Which recommendation is evidence-based? A. Prophylactic bilateral salpingo-oophorectomy, BSO, after childbearing or by age 35-40. B. Routine PAP smears prevent ovarian cancer. C. Annual breast MRI only, no gynecologic interventions needed. D. Oral contraceptives have no effect on ovarian cancer risk. Answer: A. Prophylactic bilateral salpingo-oophorectomy, BSO, after childbearing or by recommended age. Rationale: BRCA1 carriers are recommended to consider risk-reducing BSO, often around age 35 to 40 after childbearing, due to high ovarian cancer risk. OC use reduces ovarian cancer risk somewhat. Pap smear does not detect ovarian cancer. Question 44. A nurse is caring for a patient with large uterine fibroids who is Rh negative. She is scheduled for uterine artery embolization, UAE. Which blood product or prophylaxis is indicated? A. Rho, D. Immune globulin if the patient is Rh negative and there's potential fetal maternal hemorrhage. B. No special treatment for Rh status in UAE. C. Transfuse platelets prophylactically. D. Administer heparin prophylactically. Answer: B. No special treatment for Rh status in UAE. Rationale: Rho, D. Immune globulin is for prevention of alloimmunization related to fetal blood exposure, pregnancy-related. UAE is not associated with fetal blood exposure. ROGAM is not indicated specifically for UAE. Platelet transfusion or heparin prophylaxis are not routine in UAE pre-op. Question 45. Select all that apply. Which are signs/symptoms of uterine inversion, postpartum emergency? A. Severe postpartum hemorrhage with a mass protruding from the vagina. B. Pelvic pain and shock out of proportion to blood loss. C. Hypertension and bradycardia. D. Failure of placenta to deliver with a well-contracted uterus. Answer: A, B. Rationale: uterine inversion presents with hemorrhage, a mass at the introitus, and shock. Hypertension/bradycardia is not characteristic. Placenta retention with a contracted uterus is less typical of inversion. Inversion often follows pulling on cord with fundal placenta. Question 46. A 30-year-old with stage IB1 cervical cancer wants fertility preservation. Which treatment option may be considered? A. Radical trachelectomy with pelvic lymphadenectomy. B. Radical hysterectomy only. C. Chemoradiation only. D. Expectant management. Answer: A. Radical trachelectomy with pelvic lymphadenectomy. Rationale: for select early-stage cervical cancers, small tumors, negative nodes, radical trachelectomy preserves the uterus and fertility. Radical hysterectomy or chemoradiation removes fertility. Question 47. A postpartum patient developed a deep perineal hematoma after vaginal delivery and has severe pain but stable vitals. Which is the appropriate immediate management? A. Analgesia and observation. Small hematomas may be managed conservatively. B. Immediate exploratory surgery for all hematomas. C. High-dose systemic steroids. D. Start anticoagulation. Answer: A. Analgesia and observation. Small hematomas may be managed conservatively. Rationale: small, non-expanding hematomas with stable vitals can be managed conservatively with analgesia and monitoring. Expanding or large hematomas with hemodynamic compromise require surgical evacuation. Anticoagulation is contraindicated. Question 48. A patient with suspected choriocarcinoma has markedly elevated beta-HCG and lung nodules on chest X-ray. What is mainstay treatment? A. Multi-agent chemotherapy, e.g., EMACO, for high-risk metastatic GTN. B. Immediate hysterectomy only. C. Radiation therapy to lungs only. D. No treatment, spontaneous resolution is expected. Answer: A. Multi-agent chemotherapy, e.g., EMACO, for high-risk metastatic GTN. Rationale: choriocarcinoma with metastases is highly sensitive to chemotherapy. Multi-agent regimens are used for high-risk disease. Surgery and radiation are adjuncts in selected cases. Question 49. Select all that apply. Contraceptive options safe during breastfeeding include: A. Progestin-only pills, mini pill. B. Levonorgestrel IUD. C. Combined estrogen-progestin pills in the immediate postpartum period. D. Depomedroxyprogesterone injection. Answer: A, B, D. Rationale: progestin-only methods and IUDs are safe during breastfeeding. Combined estrogen pills are avoided in the early postpartum period due to decreased milk supply and thrombosis risk. Question 50. Complex prioritization plus SADA. A 42-year-old premenopausal woman presents with sudden heavy vaginal bleeding, syncope, and known uterine fibroids. Orders include: 1. For fluids and transfuse PRBCs as needed. 2. Give high-dose 4-estrogen. 3. Consult interventional radiology for uterine artery embolization. 4. Prepare for emergency hysterectomy. 5. Administer tranexamic acid. Which actions are appropriate immediate steps? Select all that apply. A. 1 and 5 only. B. 1, 3, 4. C. 1, 5, and prepare for possible 3 or 4, coordinate concurrently. D. 2 and 5 only. Answer: C. 1, 5, and prepare for possible 3 or 4, coordinate concurrently. Rationale: immediate stabilization, for fluid/transfusion, is priority. Tranexamic acid can help control bleeding. Meanwhile, coordinate possible definitive/interventional options, UAE or surgery, based on response. For estrogen is not standard acute management for heavy bleeding in this setting. Decisions about hysterectomy versus UAE depend on hemodynamics and fertility desires. If you made it this far, congratulations, you're already ahead of most Nclex test takers. Every minute you spend mastering questions like these brings you one step closer to your RN license. Now, tell me in the comments, how many did you get right? And if you want more tough Nclex questions on topics like maternal health, med-surg, and pharmacology, make sure to subscribe, turn on the bell, and watch the next video popping up on your screen right now. Keep pushing, keep believing, because the Nclex doesn't stand a chance against your preparation.